Alrighty, a wonderful and happy Thursday to all of you and anyone who is tuning in this evening. I am Rebecca Vogt. I am the Media Relations Specialist at Roswell Park Comprehensive Cancer Center in Buffalo, New York, and you are tuning into one of our Roswell Park physician webinars. Now, we are sure that, I know we are weeks and weeks and weeks into this pandemic, and questions are still popping up, probably left and right, as we continue to navigate through this. And this is, of course, a continuation of our Thursday webinars. They cover a variety of topics and also feature a number of experts, all in the hopes of becoming a resource for all of you. Now, today we are looking at preliminary results and collaborative efforts in treatment of COVID-19. I am joined by the one and only Dr. Philip McCarthy. He is the director of the Transplant and Cellular Therapy Center here at Roswell Park. Dr. McCarthy, very much welcome to you. And if you can share a bit about yourself first, I'll open up the floor to you. Oh, you are on mute. Dr. McCarthy, you probably need to unmute yourself.
Didn't do it
Yep,
right.
there you go.
Is that better? Sorry about that. It takes a while. Thank you very much for that very kind introduction. I'm Philip McCarthy. I'm one of the transplant and cellular therapy physicians here at Roswell Park. As Rebecca's pointed out, it's been a very interesting time with regards to how COVID-19 has impacted on our clinical care. And I'll be discussing today some of the things that we have found with the treatment of our patients, and look forward to your questions about the cases I'll describe.
Fantastic. Yeah, exactly. So as someone who cares for some of our most critically immunocompromised patients, Dr. McCarthy can walk us through what some of the most concerning risks he and his team for transplant patients have faced during this time, and also tell us a little bit about how we are approaching the cellular transplant process in terms of safety and precaution. Now, before he gets started, I know he has a little presentation he would like to give to everyone. We do want to always note that there is the chat bubble feature at the bottom of your screen, and you can feel free at any time to write in a question to us. We will get to them during the question and answer session after his presentation. And note that I think there is an option that make sure you send it to all panelists involved. And then also, if you want to not have your name associated with your question, you can always check mark the box that's labeled anonymous. That all being said, getting a little bit of that housekeeping out of the way, Dr. McCarthy, the floor is yours, and I will step aside.
Thank you. And if you could bring up my slides, I'll go through this fairly quickly. And next slide, please. So this is from UpToDate. If you have access to UpToDate, you can go through this fairly quickly. So I'll go through this very fast in that lymphocytopenia is something that we are concerned about in our patients, and this can occur for a variety of reasons, which I'll talk about. And there are a variety of lymphocytes that we're looking at, and the most common ones that we're interested in are T cells, B cells, and natural killer cells. These are the relative percentages in the blood of all three populations. Next slide, please. And this is something called idiopathic T-cell lymphopenia. Now, this is something that you might work up if you're in primary care, and it's just where you have somebody with a low T-cell count in the absence of something such as HIV or other cause of immunodeficiency. And so the absolute numbers are usually below 300 cells per microliter. Next slide, please. And these are the types of things you're thinking about, because not only can lymphopenia be associated with immunodeficiency, so can lymphocytosis. So you can have a variety of conditions such as viral infections, Epstein-Barr virus, hepatitis, or even bacterial infections, autoimmune disorders, other inflammatory conditions, which can result both in a low lymphocyte or a high lymphocyte count. For malignancy, some of the most common ones are chronic lymphocytic leukemia, where even though the patients have a high lymphocyte count, they can be functionally lymphopenic and thus be at risk for infections. And then there's a variety of allergic diseases as well, which can cause abnormalities in lymphocytes. Next slide. And then this was a study also from UpToDate, and it was back in the 1990s, which talked about some of the things that can cause low lymphocyte counts as a result from a bacterial or fungal infection, somebody who's post-op, malignancy as mentioned, and then the use of glucocorticoids can make patients lymphopenic, and then cytotoxic or radiation therapy, trauma, or hemorrhage. Next slide, please. And then lastly, something that's more associated with chemotherapy, against severe infections, but neutropenia. And this is directly related to the ability of the patient to fight off, in particular, bacterial infections. And this is where the absolute neutrophil count is less than 1,500. So it's mild if it's between 1,000 and 1,500, moderate 500 to 1,000, and severe is less than 500. These are patients who are at risk for spontaneous infections and could be in trouble, for example, if they were to get, for example, a COVID-19 infection. Next slide. So this just came out just a few weeks ago, and this is from the Paris group. And what they did was they looked at, next slide please, a variety of patients who from March 9th to April 4th were admitted to their unit, and they looked at 25 sequential patients who were admitted with a hematologic disease and COVID-19 infection. And of those 25 patients, 9 patients died. So there are known risk factors for COVID-19 severity: older age, comorbidities such as diabetes, cardiac disease, and then cancer. And I did send it out to Ashley earlier, Snowden earlier. There's a paper that just came out in JAMA Internal Medicine, which is a scoring system for risk of COVID-19 severity. It's from the Guangzhou Chinese group, and it gives a scoring system based on what kind of comorbidities the patient has, what's their lymphocyte count, what's their neutrophil count, and it allows for a potential prediction for outcome based on this score. Next slide, please. You can't see this very well, but it's from the article, so I apologize. And it's meant to show that these are patients that had a variety of different conditions and different ages, all with hematologic malignancies. Most of them were in the middle of their therapy, and the far right-hand column is the most important one, which talks about the relatively high death rate in this very small number of patients, again from March to April. So they really rushed this out, and again, patients died fairly quickly of the COVID-19, and it makes it very difficult because we really don't have any yet conclusive good therapy for this. Next slide. And this is just the last number of patients they had admitted. And you can see that some of these patients, there's one you can see who died who was 97 years old. So that was somebody who had pretty rapid demise in the context of age and also having myelodysplastic syndrome. Next slide, please. So I'm going to give two case stories because this really is demonstrative of either end of the spectrum, and they actually probably had the same viral infection because they actually had dinner together. So I'll explain this. So this is a 49-year-old patient who had IgA lambda multiple myeloma. We'll go through it quickly. She got induction therapy, had multiple disease progressions. So she had her lymphocytes collected for anti-B cell maturation antigen CAR T cell therapy. You probably may be familiar with this for lymphoma, and this was a protocol patient. She underwent lymphocyte depletion, so fludarabine and cyclophosphamide in February. She got her CAR T cells then as well. She became pancytopenic, but she went into complete remission. She still had some disease, minimal residual disease positive. But then late in March, she develops a COVID-19 infection while borderline pancytopenic. But then she got admitted to the hospital because her counts rapidly deteriorated, such to the point we gave her some of her old stem cells as a boost to try and get her to recover her counts. And as she recovered her counts, she went into adult respiratory distress syndrome due to COVID-19. And she's currently intubated, but she's awake. We're hopefully trying to get her off the vent because she's down to a lower oxygen. Her FiO2 is 45%. She had been on 80% when she was intubated, about 14 days ago. Next slide, please. So this is her lungs early on with her infection. She's now almost 6 weeks in, and she develops worsening lung disease over time. So this is in late March. You can see some vague abnormalities on the right-hand side of the screen. Next slide. You can see that it gets a little bit worse, but not much. Next slide. And now you can see more infiltrates, primarily on the left side of her left lung, right side of the screen, sorry. Keep going. And you now see, again, the lung is worsening in late April. Keep going, next slide. And you can see now in early May, you see more lung infiltrates. And next slide, please. And now 5 days later, her lungs are much worse. So this is right before she was intubated. So next slide. And you can see again, another shot showing the worsening infiltrates at a lower, at a different slice on her CAT scan. Next slide. So this is just showing how her CBCs over time, and you can see she's pancytopenic, but we had given her cells just a few days before, and then as we go from right to left, we can see that she gets worsening hypoxia as her neutrophil count recovered. And you can see that she's intubated there with the, as her white count's 1.62. So during her period of pancytopenia, her lungs were slowly getting worse, but they became progressively worse as her neutrophil count came in and went after all the virus that was infecting her lungs. And you can see now she's got a normal, well, not quite a normal white count, but close. And yet she's much worse off than she was 2 weeks previously. So it's a very cautionary tale in terms of how the COVID-19 just hung out in her lungs, wasn't being cleared. And now that she's got neutrophils, hopefully combined with a better lymphocyte count, we'll be able to get rid of her COVID-19. Next slide, please. So this is another patient, and it's, again, demonstrates the dichotomy in this disease. NY-ESO-1 is an embryonic antigen which is being tested for because it's expressed on certain ovarian cancers. And we're doing T-cell therapy. This is led by Dr. Kunle Odansi, one of our GYN oncologists and our scientific director. So this patient received T-cells after cyclophosphamide lymphodepletion and low-dose IL-2. And she had count recovery, and she was, that should be March 2020. And then she actually had dinner with that patient I just showed you the day after her discharge. And then she went home. She's from another part of New York State. And then she comes back in mid-April and she's got lung infiltrates, completely asymptomatic. But because she had exposure to this other patient, we tested her, and sure enough, she's COVID-19 positive. So next slide. And this is her CT scan showing, you can see on her right lung field, which is the on the left side of the screen, at the bottom of the CAT scan, there's a little white dot down there. Next slide. And you can see here where, now you can see there's an arrow, a small infiltrate, and next slide. And a few more, and then next slide. And again, you can see a little bit more infiltrate in the same area. And again, this patient's very asymptomatic. She's walking 2 miles a day. She is not hypoxic. In fact, she has an O2 sat oximetry reader at home, and she's been between 97 and 98 the entire time. Next slide. And you can see again more of that infiltrate. Next slide. So, as I mentioned, walking 1 to 2 miles a day. She was just seen about 3 days ago with right foot cellulitis. She's now on PO antibiotics. And in the emergency room, again, her oxygen saturation was just fine. Her chest X-ray looked okay. They didn't do a CAT scan. And she still remains COVID-19 positive. So you can see here, there's a huge difference in the outcomes of these patients. Are we're hoping our first patient will get better. But this patient, even though she received lymphodepletion chemotherapy, she's fine. And she's received no, well, there really is, it's not clear if remdesivir was not readily available, so we didn't have it for either of these patients. But again, you have 2 completely different clinical courses. So next slide. So then the last thing I wanted to talk about It's occurred in especially the first patient. The first patient developed coagulopathy. She had an elevated fibrinogen, D-dimers, so especially as she went into ARDS. And we have not given her blood products. She's had no active bleeding. We're trying to treat her underlying condition. In fact, if anything, it's recommended you give DVT prophylaxis with, for example, enoxaparin. And I've given the URL. This is from the American Society of Hematology website. So again, cautionary tales on what can happen with this. Patients with cancer can get severely ill. We've seen that from the French data. We're very, very concerned about our own patient population. So right now, all our patients being admitted for inpatient treatment are getting screened for COVID-19. If they're positive, we will delay therapy. So far that hasn't happened, but we've been very aggressive about making sure that our patients are socially distant. People don't like to say socially isolated, and so that we are cautious with them. A lot of our patients have to practice this anyways because they're immunosuppressed for extended period of times, but it's led to a complete change in how we manage our patients. And I think the next slide is my last one. Yes, thank you for listening. So questions?
Fantastic. So yeah, just a reminder again to anyone who's tuning in, you can always drop something down onto the chat button as we answer these. And I do have just a couple of quick ones that we want to toss your way sort of pre-submitted. So one of those things first is, Dr. McCarthy, are transplant patients in this situation that we're in right now required to stay in inpatient longer than they would normally be?
It's actually interesting. We are actually admitting them earlier because fortunately, the turnaround time for screening used to be like 2 or 3 days. In some cities, that's still the case, which is very difficult. We now have turnaround time fairly quickly. We can get it usually same day. And so we're admitting the patient because they're being screened for COVID-19. We have to put them on isolation. So we usually put them in a room, we give them lunch, and we tell them, you can't come out, sorry, until it comes out. It's negative, then we start the process. So we've added actually an extra day on the front end. It's interesting, when this first started happening, we had a young man who had count recovered, he was ready to go home, and his family was freaking out saying, no, we don't want to take him home. You have to keep him. We're like, we can't keep him for the next 3 months. So so a lot of people are very scared about this. So it required a lot of reassurance saying, look, if you go home, you stay socially distant, you don't go out and about, and make sure that your caregivers aren't going out and about. In fact, we have somebody who's being admitted, and when he's discharged, he said, what should I do about my caregivers? Well, fortunately, he's going to be in a city in New York State where they can do screening. So they can get screened, and you can just drive up. You have to make an appointment, but you can just drive up, get screened, and reassure yourself that you're not an asymptomatic carrier. So it's changed a lot of things. And now that we have more available testing, it was very frustrating 2 months ago when we had limited testing. Now that it's becoming more available and we really need to do even more, it will be reassuring for our patients, their caregivers, and also the clinical team taking care of these patients, because the last thing we need is for COVID-19 to occur in our unit. We don't know it, and it potentially could get spread rapidly because this is a pretty insidious virus.
And considering the patients that you guys handle on a day-to-day basis, I mean, anyone who comes to Roswell Park, does have that immunocompromised immune system. So, but especially with BMT and TCT, I'm sure that's even more so. So I know you touched a little bit upon it, but is there any other sort of reassurances that you are telling to patients and their families as they go home, so that they are not in that sort of similar situation of, I want to stay here for 3 months?
Yeah, in fact, what happened was a few weeks ago, because we hadn't been testing all patients be admitted, the Institute went and tested everybody who was on the inpatient service. Screened, we didn't find a positive, thank goodness. So it also goes to show that we are very careful about our inpatients. We're also very careful about our employees, and we have wonderful nurses who every day come in and take care of our patients. And they have to come in, as do I, They ask me all the questions about symptoms, and they check my temperature. And we now have the capability, if you're nervous about anything, because it's allergy season, so I am constantly congested. And when I was exposed to that, I happened to be exposed to that first patient we described, who essentially just had some sniffles, and I had a very astute PA who decided to test her, and she was positive. So we both were paranoid and decided we should get ourselves tested. We were both negative, and we were reassured. So we have that capability for our staff if they have any symptoms. So we've had a few staff members who have gotten tested because they had symptoms. Some of them were even minor symptoms. And if somebody has exposure and we're concerned about it, we will get them tested, because the last thing we need, of course, is to have this get into the hospital without us knowing about it.
Of course not. Of course not. And speaking of patients who are inpatient, in order for them to be able to leave the hospital, is there any sort of requirement right now for them to
Sure.
have a higher white blood cell count?
Oh yeah, well, we do this anyways. We don't usually discharge patients with low blood counts. We want them to have count recovery. The problem though is even with count recovery, you're still immunosuppressed. And so that's why we caution our patients. We used to tell them, if you go to the movies, go on a Tuesday afternoon at 2 p.m. when there's nobody there, and you could go to and wipe down your seat. Now you can't go to the movies anyways. You can go to a drive-in, and you can sit in your car. And we had always told people, don't go to a salad bar. Well, you can't do that now anyways. But once restaurants open up, I would not be recommending anybody go to a salad bar, because at least there's good data to show that this virus can be spread quite easily. And there probably was viral spread of other viruses, rhinovirus, enterovirus, and these are things that people would just pick up, but you wouldn't get a life-threatening illness from it, but our patients could. So parainfluenza or influenza in our patient population could be quite serious. So we do recommend social isolation for at least a period of time after the patients are discharged from the hospital, in addition to having count recovery.
And we do have a question that did just come in. So apologies first off if I pronounce anything very strangely, but it says patients on Remicade or Humid A for IBD with mild neutropenia. Do you advise to hold off on their infusions and switch to oral medications?
Well, that's a good question. I've talked with some of my colleagues about this for a variety of the monoclonals that are being utilized. It's like, can you take a drug holiday? But the problem is if the IBD, the inflammatory bowel disease, flares, then you're going to be in a position where you're going to have to aggressively treat the patient. So I think if the patient's in a position where they're not going to be exposed, they're able to socially isolate, like for example, their spouse or somebody in their home is not an EMT or a fire person or fireman, firewoman who has to go out and get exposed to the public, that would raise their risk. But if they're in a position where they can stay socially distant and can come in and get their therapies, I think it would be at least a reasonable consideration to continue without stopping. But right now, it's a really good question, and I think it will vary on the person's risk in terms of where they live. Also, where they live. If you're in Manhattan, it might be a bigger deal than if you're in a rural setting where there's just not a lot of people you're going to be exposed to.
Excellent. So thank you for submitting that question. We very much appreciate that. One other thing I did want to touch on, because you already said that we haven't had to delay any treatments, since the pandemic began. Is this affecting clinical trial enrollment?
Oh
Anything to
yeah.
add on that end?
Yeah, well, we did delay some therapies that didn't have to occur right away. So for example, some of our patients who needed a stem cell transplant, they had bad leukemia. We couldn't wait. So we just went ahead with those. There were some lower risk patients that we pushed off for about a month. And then now, once we had a better handle on what was going to happen, because we were very concerned that there could be a huge influx of COVID-19 patients, now that we've been able to manage that and not have that happen, we have been able to ramp up and do patients who are lower risk. And so it's allowed us to be able to do that. And I'm sorry, the second part of your question?
All it had said was, do you advise to hold off on their infusions and switch to oral medication?
That's another question. Yeah, that's a good question, because if you're going in and out of an infusion center where there's a low level of testing, in other words, you're not able to test and you're worried about exposure to other people, then yeah, there is a move to switch to oral medication. So for example, for multiple myeloma, um, lenalidomide, dexamethasone can be given orally. There's another drug called Ixazomib, also oral. The subcutaneous form of a proteasome inhibitor, which is Ixazomib, is an oral form, bortezomib sub-Q, carfilzomib IV. And there is a move to say, well, maybe we should switch to Ixazomib, which is an oral agent during the time of uncertainty when we're not certain if the patient's going to be exposed. So I think as we roll out universal testing, it'll be less of a concern. And thus, I think patients will feel more safe, and clinicians will feel safer allowing these patients to come back to the infusion clinic to receive their therapies.
We are getting very close to 6:30, and I'm not seeing a whole lot of questions pop up anymore. I'm just kind of wondering if there's any sort of closing thoughts you have, Dr. McCarthy, that you would like to pass along to everyone this evening.
Yeah, this is difficult because we don't know when this is really going to end. I think that we really need a vaccine. That's still far off. We need universal testing. We need a reliable antibody test so we can measure who has actually been exposed. That may give us some reassurance, although we're not even certain that if you have seen this bug once before, will that antibody be protective from a future infection? We just don't know that. So we need a lot more information, a lot more study on this. And so I think it's critically important that we report all our results. We've been asked to report our patient results we participate in a transplant registry, so all our transplant patients are still being reported, our cellular therapy patients. So for example, the two patients I talked about today, their results will be reported to a registry, and we'll aggregate all that data to be able to look at it. So I think we really have to get together. You've seen that there's been a little bit of infighting about when can we relax rules, when can we not. The last thing we need are people carrying armed weapons into situations where they really don't belong. We really need to sit down and discuss this rationally so that we can approach it best for our patients and the public in general, so that we make it as safe as possible for everyone.
Fantastic. Thank you, Dr. McCarthy. And actually, we do have a last-minute question that came in if you're willing to answer it.
Of course.
It is, does this virus have affinity to transplanted organs?
Oh, I must admit, I don't think it's so much, its affinity is to the respiratory tract. So really, it seems to want to get into our respiratory tract and then later into our lungs. So there's some evidence that it causes this coagulopathy and terrible clotting problems in some people. It does seem to get into organs, and in fact, it causes a syndrome that's similar to Kawasaki's disease in children in particular. I don't think it has necessarily an affinity for transplanted organs so much as the immunosuppression allows the virus to get in and wreak havoc on a variety of organ systems, but primarily the lungs are the major target. Although you're right, there are other organs that are being targeted by this, and we just don't understand a lot of the mechanisms of how this is occurring.
I think, as I had mentioned last week in our chat, is that, again, you keep on saying there's so many unknowns in this, and this is like everything we're kind of just working through one day, 1 week, 1 month at a time. And it's the stuff that is all going to end up in sort of the future medical books. I'm certain of it. So yeah, that all being said, we do want to thank everyone for tuning in this evening. Dr. McCarthy, thank you for taking time out of your schedule to put on that presentation and also entertain some of these questions that have come in from our attendees. That all being said, if any of your questions were not answered, and, if we end this chat and you all of a sudden think, oh, darn, I have a question I wanted to ask Dr. McCarthy, or something else from another topic, we do encourage you to continue to tune into our future webinars. They will address even more topics as we move forward and answer more of your questions. We do also want to point out that we consistently update our COVID-19 page on our website that has additional FAQs and more, and you can always check that out at roswellpark.org/coronavirus. The video from today will be available to view on demand in case you have any physicians or other healthcare professionals that did not have the time to tune in this evening and you want to give them a little nudge and say, hey, tune in, this is a great presentation. The link will be sent to your email, so feel free to share. We also encourage you to stay tuned to roswellpark.org/live chats and also tune into your email to register for any and all upcoming webinars. Have a good evening, everyone. Again, thank you for tuning in, and we'll see you next time. Bye.
Thank you.